on to a very interesting talk that I don't know anything about. And for that reason, I'm excited to hear about it. This is Dr. Nicholas Colyvas, and we're going to be learning about blood flow restriction therapy. Is this a real advance in muscle growth and recovery? And Dr. Colyvas is clinical professor of orthopedic surgery at UCSF, specializing in minimally invasive orthopedic or arthroscopic surgery of the knee and shoulder, particular interest in meniscus repair, rotator cuff surgery, and biceps tendon surgery. He has extensive experience treating athletes of all types, both professional and amateur, and has served as a team physician for numerous sports, including rugby and football teams. And just before he gets started, I'm going to point out that following this session, we do have a short break and networking with exhibitors. If you go to your COA virtual conference link, you will see that there is the exhibit hall at the top. If you click on that, you can visit our sponsors. Again, we can't do this meeting without our sponsors. And by clicking on any of the videos or links within the exhibitor, you have earned yourself a golden ticket. The golden ticket will go into a raffle, the same types of raffles we have every year. You can get free registration to future COA meetings. You can get an upgrade at your next COA meeting. You can get $50 and $100 gift certificates that have been donated. So take a few minutes, grab a drink, stretch your legs, but be sure to click on a few of the exhibitors. Without any further delay, I will introduce Dr. Colyvas, and looking forward to his talk. Thank you.
Great, thank you. Oren, can you hear me? All good.
Yes.
Okay. Thank you. I'm Nick Colyvas, clinical professor at UCSF. I'm going to present on blood flow restriction therapy and whether this is something we should be using for our patients. I think the audience, there's probably many people who use it already, some that don't, some that know a lot, some that know little. I'm going to try and clarify a little bit of what we have here. I have no disclosures, except that I do want to give a shout out to Krista Prado, who has really taught me a lot about BFR, and I think is one of the foremost practitioners of this particular therapy here at UCSF. And this is what we're looking at really is blood flow restriction on the upper thigh there. You can see the difference in the legs there, and just doing your exercises with a restricted blood flow. So I'm going to try and give us a basic understanding of BFRT in 15 minutes, looking at a little bit of the literature, highlighting some of the concerns, and trying to sort of figure out which is the best group of patients for whom we can use this in our orthopedic practices. Some of the real basics, obviously we all know skeletal muscle is constantly adapting. It's sometimes frightening to see how quickly our patients atrophy after surgery or after injury. And the traditional prescription for strength improvement is 70% of one rep max to stimulate and build muscle. And just as a reminder, one rep max is the maximum amount of force that can be generated in one maximal concentration. And it can be measured either through maximal testing, or usually more commonly, a bit safer and quicker, through submaximal testing, and then using one of, there's probably 20 different formulas out there. These are the two most common, where W is weight and R is repetitions. And essentially, when you send your patient for strength training to your physical therapist, they're going to use somewhere between 65 to 100% of one rep max to get that stimulation of the muscle for hypertrophy. That does, however, load the tissues, loads the muscle, loads the tendons, loads the tendon bone junctions significantly. And we all know some of our patients don't tolerate that very well. So is there an alternative? Sorry, I got the wrong way. Well, one of the attractive potentials of blood flow restriction is that instead of using that 70 to 100% of one rep max, we may be able to achieve the same or similar results using 20 to 40% of one rep max. And so, like many things in orthopedics, this is not new. It's just seen a bit of a resurgence more lately. When it goes back to the 70s, in Japan, it was called katsu training. And in the last 5 years, there's been a big uptick in the interest a lot of that driven by the performance and exercise industry. And basically it combines the use of metabolic stress and a mechanical stress in combination rather than just mechanical stress, which our standard techniques use, to really stimulate muscle strength hypertrophy. And it's now actually fairly mainstream. If you look up BFR, you'll see a lot of this type of thing. You'll see a lot of the sort of exercise industry trying to promote it. And there is some validity behind that, and we'll talk about that in a little bit. But really what we want to figure out, is this something that we can use for our patients? And particularly, is it attractive for those patients we typically have problems building muscle strength in? Our injured patients, the post-op patients, many of my meniscus repair patients atrophy dramatically quickly. Older patients, many of these people are just not able to tolerate that high load training. And it certainly may be useful for athletic performance training. Tim McAdams brought this up for some of the pro teams are using it, and they use it heavily. And there's some evidence pointing in that direction. I'll go into that a little bit. And certainly it's popularized at this point. And maybe it's not really an alternative to our high load training, but an adjunct really, I think, is something that's what we could look at it more accurately as. If you want a good review study, this out of the Yellow Journal last year, this is VOPAT study. I'll use some of their tables, but just to highlight some of the studies, pretty much all of which show that there is improvement in strength. But if you look at the studies in more detail, they bring up some other things that are interesting as well. So this is the Hugh study out of the British Journal of Sports Medicine. They pooled data. They showed increasing strength when you added BFR to low load training. One of the things they brought up, and which you see across the studies, is that although you do see this improvement using BFR, it's typically less effective than our standard heavy load training. And that's something that's consistently found in the studies. Another study, this Baker study, 2020, again showed improvement. This is a systematic review, I guess, showed improvement across the board. And this one nicely showed that that is available also to our older patients in older than 50 years old age group, which I think 50 is actually probably a little bit on the low side these days to consider quote unquote older. But anyway, what this highlighted is something that I'll bring up more often here, is that one of the problems with all of these studies is the heterogeneity of the protocols, of the standards that are used, the numbers that are used for calculating the occlusion pressures, et cetera, et cetera. This study out of UCSF, again, shows improvement in atrophy for postoperative knee patients. Points out no serious adverse effects, again, something that most of the studies are showing, but does point out that you do need proper training and you do need some equipment. It's not super expensive, but you do need some equipment for this. And again, points out that specific protocols and parameters are just not standardized at this point in time. This is from the VOPAT study and separates out, I think, the three groups that really look attractive for BFR. One is the elderly patient, the older patient, and this sort of tabulates the groups, somewhat small numbers of each groups, but all show improvement. But this also shows that the exercise, the frequency, the size of the cuff, the amount of pressure used is different in all of them. So again, not standardized. And I think that's a general problem with the literature on all of this BFR studies. When you're looking at the second group that I think this is helpful for, the rehab group, post-op patients, we're actually in a study right now looking at post-op meniscus repair patients. And the studies, again, all show improvement in strength, and again show variation in how that's done. But again, this sort of general significant positive trend in terms of the strength. I will address to some degree how it actually works in a little bit here. That was one of the questions that just came through. So the group for whom we're probably seeing most people using it now is the sort of performance industry and the exercise strength in young, healthy patients. And this is the tabulation of the sort of rugby players, college football players, again, all showing increases in strength, but how often it's used, how long it's used is all variable. One interesting finding here, that is coming up now is that there's a potential for the VO2 max to be increased as well using BFR. And I think that's going to take a fair amount of study to kind of clarify a little bit more. But interesting and potentially exciting. So how do you do it? Well, basically, it's a very simple piece of machinery, which is something we've seen and we use all the time, which is a blood pressure cuff. It's placed on the upper limb and the venous flow is occluded. And a degree of the arterial pressure is also occluded. Now, what that actually is, many of the studies use 80%, many of the standard protocols at 80%, but many times that is actually an unknown, and many times other pressures are used, and there is studies that show that it may not make a difference what pressure is used as long as you get essentially complete venous occlusion and some arterial occlusion. Multiple different types of cuffs out there, some of them more sophisticated than others, but generally your physical therapists that are doing BFR are using a cuff, an individualized cuff that can measure the pressures, measure the occlusion pressure, and then apply a specific arterial occlusion pressure per their protocol. And what this is a protocol that we use for patients, but this is very, very variable. How many reps you do, how many times a week. Tim was talking about the pro athletes doing it, 16 times a week. It varies all over the place. So this is just one of the typical type of routines we use. Now, if you've tried it, it's kind of interesting. You've got these little weights, you think it wouldn't be very difficult, but once you occlude your blood pressure, you really actually are working quite hard to make that weight go up and down, and you can actually feel the burn. And it's surprisingly more difficult than it looks or than you would intuitively think it would be, which makes sense since you're trying to essentially exhaust those muscles before they would be under high load training. To answer the question of how it actually works, I think there's a fair amount of data in there in the literature. The reality is the actual mechanism or pathway isn't fully understood or clearly identified. From the point of view of the occlusion, the vascular occlusion, it seems to work on both the arterial and the venous side. There seems to be muscle activation of metabolites, buildup of lactate, the hypoxia, all stimulates pathways that include all of these things, signaling the hypertrophy mechanisms. And there's likely some contribution from the venous side as well to doing that. But as to nailing down exactly what the pathway is, there's nothing in the literature that shows that very clearly. But what we are looking at is that this is not just a occlusion phenomenon. It has to be combined with the exercise. So one of the biggest concerns about all of this sort of occlusion of the vessels and potential side effects and potential problems is sort of intuitively the DVT risk. And this has been studied. There are some big studies out there, including some bigger number studies as well. So DVT doesn't appear to be a risk, although we might intuitively think it might be. And in fact, the studies have gone into a little bit more detail, looking at fibrin D dimers and fibrinogens, which would be elevated in sort of a concerning situation, and those don't go up. And there is one actual study that shows that it might actually stimulate the fibrinolytic system, which works in the opposite direction. So DVT fortunately does not appear to be a big concern. The one thing that happens commonly, or relatively commonly, is subcutaneous hemorrhaging, so this sort of bruising look. And then the other sort of quote unquote complications really are very minimal: numbness, lightheadedness. People report their varicose veins look worse afterwards. These things are relatively not that concerning. One thing that is potentially concerning, hasn't really been highlighted yet as a major issue, but something that I think theoretically is a concern, is that the normal response to exercise is the sympathetic activity increase that increases your heart rate, increases your blood pressure due to the metabolic increase in lactate and hydrogen ions. And it is known that BFR actually exaggerates this exercise pressor reflex. So there is a concern in your patients that have underlying cardiovascular issues, particularly if it's pretty significant. And many of our older patients may fall into this group, that you're enhancing this EPR effect and you might be triggering some issues. This is still potential, but I think deserves more study at this point in time. So what would be the contraindications? As pointed out, the significant cardiovascular disease, open wounds and soft tissue that you don't want to make more edematous and concerning. Venous insufficiency, probably bad varicose veins and things like that should be considered a problem. Pregnancy, probably best avoided. If there's a strong history of DVTs or PEs, or a strong family history, or a history of Leiden trait or something like that, and any hypercoagulable state like an active cancer state, those are probably reasons to avoid considering BFR. What about the future for BFR? Well, all of this is all predicated on the idea that much of this needs to be standardized, and a sort of standard protocol, or at least some set of rules that standardizes what pressures are used, what protocols are used, so that apples can be compared to apples, I think are important. I'm involved in this study looking at blood flow restriction after meniscus repair. Many of my patients really atrophy very quickly, despite the fact we're trying to weight bear them earlier, et cetera, exercise them as much as possible. So this may be a benefit there. This question of VO2 max could actually, as one of the questions came through, could actually be a very important enhancement that BFR might give us. I don't think that is as yet something that's proven adequately. I think there's a lot of studies that are underway to try and see if that's the case, because that would be a very significant factor for our performance athletes, obviously. There is one interesting study that looks at cross-sectional tendon area and improvement after BFR. I think that's another curious and potentially very interesting application here, if it actually is real. So in summary, I think that we can consider BFR both effective and relatively safe if it's avoided in those patients I pointed out. I think there are problems with the way it's studied, and it's sort of inherent in the nature of the fact that cuffs are different and all these protocols are different with all the different physical therapists. But some level of standardization would probably help us to make reasonable comparisons. I certainly have, and I think you should consider, if you have people who, therapists who do BFR in your area, if you're not already doing it, those patients for whom you're concerned, or who have lost a lot of strength already and have difficulty because of whatever their problem is, their injury or their age, in building that muscle back up again, in considering BFR, and adding it mostly as an adjunct. I don't think it's replacing anything at this point in time, but I think it's a good adjunct for our patients. And with that, I'll end and see if anyone has any questions.
That was fantastic. Thank you so much. I do know that you addressed a couple of the questions on the panel. I'll give an opportunity for anybody to ask a question in the Q&A. All right, I think we'll call it there. Thank you so much. That was fantastic.